Three, two, one. Sir, we are live now. Now we can start the meeting.
Thank you, Mershi. So, dear friends, welcome to our next installment of Bombay Spine Society's Residents and Fellow Spine Training Program. We have had three lectures before. Today's topic is spondylolisthesis, and we have with us Dr. Vikash Gupte, Dr. Vishal Peshattiwar, Dr. Amandeep Gujral, and Dr. Rohan Gala as faculty. And the session will be moderated by Dr. Raghuprasad Varma. He'll be also presenting some cases and we'll be grilling the faculties as well as the attendees to get the in detail knowledge about the spondylolisthesis treatment. We would like to thank Aquila Intas, who are the sponsor for this program for us. And some of the products are as shown here on the screen. Some of them which we are using very commonly, like Gabapin and T, etc. So we would like to thank you them for sponsoring this program. We also have upcoming annual meeting of Bombay Spine Society, BSSCon 2024. We have had two successful physical meetings in the past in 2022 and 2023, and we are coming with this next meeting in the month of June. This year we are doing this meeting outstation in Karjat. So we have booked a property for this named Oleander Farms. Few seats and rooms have been left, so whoever is interested can register to the BombaySpineSociety.com website, or they can go to the bsscon2024.com website also. Raghu, I would like to give the proceedings to you, so you can start the session, please. Thank you.
So you'll have to go out. I'll start sharing my screen. Thank you, Amit. Thank you, Kshitij, and welcome to you all. Our topic for the day is lumbar spondylolisthesis, and it was a topic which would bring in a lot of bone of contention about 15 years ago if we had a conference which had a session with it. It would also create a different treatment protocols defined by different surgeons at different points of time, and therefore always there would be a disagreement and we would all agree to disagree. Over the last 5 years, we've noticed that there is some consensus that's developed, and we'll try to bring out that consensus so that our next generation is well versed with how to approach case of lumbar spondylolisthesis. Like Amit and Kshitij said, I have a wonderful faculty, younger guns of Rohan and Amandeep. The ever young Vishal, I presume, would join in a while, and not so old Dr. Gupte, with his wise experience of so many years, will enlighten us and help us through. I moderate here. I'm Dr. Raghuprasad Varma. Mind you, we want this to be interactive. So all the fellows and residents, I don't want you all to hide. We are orthopedic surgeons and we love interactions and we love kind of pulling each other's legs, isn't it? So let this be interactive. So I will pick a few, just like we want the faculty to come out, some of our fellows also to come out and be involved. On that note, the textbook diagnosis or textbook, if I might say, definition is slipping forward of the vertebral bone. And we've read through this umpteen number of times with our standard orthopedic textbooks, isn't it? So the term listhesis means to step forward. Now, when does something slip or step forward? It's when you have instability. And what are the stabilizers in the spine? We know it's the disc, it's the facets, it's the pars, which is the bony block between two facets. And when these buckle, along with, mind you, the muscles and other tissue stabilizers, whether it's the ligaments or many other, where listhesis actually happens. And we knew this, but we are reiterating this before we start the session. But look at scenarios. This is a 36-year-old homemaker, always had some low back pain. She could stand 1 hour to cook. She could walk about an hour in the mall without a problem, but back pain was her problem. Or a 66-year-old chartered accountant who travels from Borivali to Churchgate in a local train, first class, mind you. But if he doesn't get a seat in the first class on one of those days, he finds it struggling enough to actually need to sit on the floor. This is listhesis too. Or a 26-year-old neurologist who's recently given birth 6 months ago, sudden onset. She always knew she had listhesis because obviously she was a medical student, but sudden onset lower limb pain in the right side, which is approached differently. Or a 60-year-old traveling in the Mumbai expressway or from here to Pune has a sudden road traffic accident, a truck hits him from the back, a listhesis, but traumatic. Or a young 11-year-old budding cricketer who says when his coach makes him play a sweep shot, he had this snap that happened in the back. All of them have something to do with instability, whether lysis or listhesis. But do we approach them the same? Not at all. Their approaches are different. So for the same pathology of listhesis, we approach them differently. Now, how do we know how to approach? That's when we get the types and classification in place. So to know about the types and classifications of listhesis, I would like to invite Dr. Rohan Gala, who will tell us about his talk, which talks about types and classification. So Rohan, off to you. You can share your screen and start off with the talk. Your mic is off, Rohan.
I thank BSS for giving me this opportunity, and thank you, Raghu sir. I will just omit my first slide because you had already spoken about it. So essentially, I will be speaking about the classification and types of spondylolisthesis. So the first grading or the type of spondylolisthesis was described by Meerding back in the days, where he thought of talking about the amount of sacral end plate which was uncovered after the slip and dividing it by the total width of the sacral end plate. This was the sacral end plate which was taken into consideration, and the amount that was left uncovered was further divided by the total width, and a percentage grade was defined by him. So it was A upon B by 100, and based on that, he classified them into 4 grades. Grade 1 was 0 to 25%, grade 2 was 25 to 50%, grade 3 was 50 to 75%, and grade 4 was 75 to 100%. There was another grade as well, which was grade 5, which was spondylooptosis. So we classified these grades as low grade, which was grade 1 and 2, and whereas grade 3, 4, and 5 were considered as high grades. Later on, Wiltsey, Newman, and McNabb developed another classification in 1981, where they divided spondylolisthesis essentially as dysplastic, ischemic, degenerative, traumatic, pathological, and postoperative or iatrogenic. Now, I will describe each type in detail. So as we all know, there's a bony hook, which is comprised of the pedicle, the pars, the inferior facet of L5, and the sacral facet. They all form a bony hook that prevents that slippage of L5 across the sacral end plate. Now, if the sacral agenesis exists, that's where the bony hook is lost, and that is where you have dysplasia, where you have a poorly developed superior facet of the sacrum, leading to a slight slip, and can also lead to a high-grade listhesis. This X-ray out here, as you can see, all the facets are well in alignment, whereas when you come to the L5 S1, you can see the poorly developed S1 facet, and the L5 inferior articular process is okay, causing the translation of L5 over S1. Now, ischemic type has had 3 types according to them, where there was type 2A, which was lytic, which was due to the fatigue fracture of the pars or the stress fracture. Type 2B was the elongated pars due to the repetitive healed fractures. The pars got elongated, but it was still intact. And there was an acute traumatic fracture of the pars, which was type 2C. So type 2A is the standard fatigue or stress fracture of the pars, which we commonly know as spondylolysis. This is a clear-cut classical X-ray where there is a breach in the pars, the breach in the continuity of the pars, and this is the type 2A. Type 2B is an elongated pars where there are microfractures in the pars, leading to it healing in an elongated position. And this is where you can still see that the pars is intact, but it's elongated, causing the vertebra to slip over the other. That's the normal pars of the L4 as compared to the elongated pars of the L5. Type C is an acute traumatic fracture of the pars. It is quite uncommon and it usually requires oblique views or CT scans for visualization. Now, the beauty of this is there is no fracture of the pars. There's usually facet fracture or pedicle fracture. Now, this X-ray shows some translation of L5 over S1. But whereas you do a CT scan, the pars is completely intact. It is actually the facet which has fractured below, causing the translation. There you can see both the pars are intact and the facet causing translation. Now, the most common type is the degenerative spondylolisthesis, which usually occurs at L4-5. As per the Kekardi-Willis classification, when you have a lot of intersegmental instability, which is long standing, which is the second stage, this leads to remodeling of the articular processes. The articular processes have unequal distribution where one rotates more than the other, leading to some sort of a facetal tropism where one facet gets sagittally oriented than the other, and which leads to further asymmetrical degeneration. The CT on your right, you can see that how the facets are oriented. One is more oblique than the other. This is what I mean by facet tropism, where the difference between both of their orientation is more than 10 degrees. So this is a typical picture of the degenerative spondy, where you have the integrity of pars and you have hypermobility at the facets, where the facet orientation again are different, where you have one facet more sagittally oriented than the other, leading to claudication and other symptoms. Now, the pathological type is due to any pathology which is pyogenic, tubercular, mainly infective. It could be neoplastic or metabolic. Now, consider this retrolisthesis which has occurred because of some discitis. Now, the limitation of this classification was that it was not able to predict the progression and response to surgery. And it was also difficult to identify the type to be exact, like this case where you had an elongated pars as well as a sacral agenesis. So there was a dysplastic variant as well along with the elongation. So where to classify them and how to predict as to whether it would progress or not. So later on, Marchetti and Bartolozzi in 1994 came up with an etiology-based classification. They just grouped the previous types based on their behavior and prognosis. They were able to actually predict the slip by identifying them into low-grade versus high-grade slips. But eventually what they did was they just took the dysplastic and the isthmic and they reshuffled them and they further classified them into low-grade and high-grade. So the dysplastic became developmental, which was one major category, where they paired that with high dysplastic and low dysplastic, which was with or without elongated pars or lysis, whereas the fatigue fracture, the traumatic fracture, the stress fracture, pathological fracture, and iatrogenic fracture were all categorized into acquired types. So they just took the elongation variant of the second grade as per Wiltse and merged them into the developmental category with high dysplastic and low dysplastic. So this is essentially the Marchetti and Bartolozzi classification, where you have the acquired categories and the high dysplastic and low dysplastic categories, both having elongation of pars as well as interarticular lysis. So coming to high dysplastic versus low dysplastic, now there are very certain telltale features like the dome-shaped sacrum, the trapezoidal L5, the degree of slip. You can easily differentiate between the two without any further ado, because when you see the low dysplastic, there's something wrong with it. Yeah, so when you see the low dysplastic, it has a very flat sacrum. It has a rectangular L5. There is no trapezoidal problem. There is no segmental kyphosis. There is less risk of progression because there is no compensatory hyperlordosis present there. And the sacrum has not verticalized as you can see in the high dysplastic. So the major points to catch here is that there's a trapezoidal L5, a dome-shaped sacrum, a segmental kyphosis, there's an interrupted pars, and it has progressed much more highly as compared to a low dysplastic, which has a flat sacrum, a rectangular L5. There is no segmental kyphosis, and therefore there's less risk of progression. Now to revise these again, myodine grades are just percentage where the first two grades are low grade and the third and fourth grades are high grade, including spondylooptosis. We'll see the dysplastic component and the ischemic component and the degenerative component and the traumatic component, pathological and post-surgical, of which the dysplastic and the ischemic component have gone into the developmental part, except the stress fracture, the traumatic fracture to the pars, and the remaining third, fourth, fifth, and sixth, they come into the acquired causes of Marchetti and Bartolozzi. Now, what is the importance of the sacropelvic balance? So, Labelle had actually stressed upon this, and he had concluded that pelvic anatomy has a direct influence on the development of spondylolisthesis. Now, based on this, they had developed a spine deformity study group classification, which was purely based on pelvic parameters and the effect on overall global spinal alignment. So before we move to that, we have to know certain parameters, which is the pelvic incidence, the sacral slope, and the pelvic tilt. These will be discussed further in the lectures later, but this is what this classification is essentially based upon. So what do I mean when I have a low PI? What do I mean when I have a normal PI? And what do I mean by the high PI? So a low PI will always have a low pelvic tilt and a low sacral slope and less shear at the lumbosacral junction, and therefore a less risk of progression. A high PI, on the other hand, will have a high pelvic tilt, will have a high sacral slope and high shear at lumbosacral junction, leading to a higher risk of progression. So of which the pelvic tilt and the sacral slope are usually changeable because they change with position. The only fixed value here is the pelvic incidence, which is actually nothing but the summation of pelvic tilt with sacral slope. So what do we mean when you have a balanced pelvis? Our pelvis is usually anteverted, but because the body compensates over time to accommodate the slip, we can have a retroverted pelvis, and then the pelvis becomes unbalanced, where we kind of compensate, the lumbosacral kyphosis worsens, and therefore there is increase in the tilt of the pelvis, whereas there is decrease in the sacral slope because we try to get the sacrum underneath the L5 just to maintain our sagittal balance. So that is the compensation that occurs there. So this is the SDSG classification, which is purely based on the pelvic incidence and the sacral slope, where you have low PI, where you have normal PI, and when you have high PI with either a balanced pelvis or an unbalanced pelvis. Mind you, to apply this classification, you need whole spine standing lateral scanograms, or at least a lateral LS spine standing X-ray, including both femoral heads. Without that, you cannot classify, or I mean, you cannot calculate the sagittal balance parameters. So what impact does the positive sagittal balance have in adult spinal deformity? The symptoms over time will increase when you have a positive sagittal balance. What I mean by that is, this is positive sagittal balance, the image to your left. The moment the plumb line falls, the plumb line usually falls on the posterior superior aspect of the sacral end plate, and it upwards when it goes from the center of the C7 body. But if it falls in front, then the body starts compensating. So this is the impact that it will have in spondylolisthesis. And this is overall the compensatory mechanism that we can have in positive sagittal balance, where you try to get the sacrum underneath that slip. And in order to do that, not only do you retrovert the pelvis, you slightly flex your hip and the knee so that you make that compensation just to kind of align yourself sagittally. So my points here to remember are that there are several classification systems which can be used, but they have their limitations. Now, with the ever-growing importance of this SDSG classification, which helps us not only to assess and plan the case, but also to prevent flatbacks and adjacent segment diseases. And one must not forget that this classification can only be applied to weight-bearing X-rays, which have standing X-rays, including both femoral heads, and in certain cases, a long-standing lateral spine scanogram. Thank you.
So thanks, Rohan, for that wonderful lecture here. So as Rohan goes out and stops sharing his let's have a few questions ready. If the fellows aren't ready with any questions, let me start off asking the first question, if I might. So, Rohan, we know classifications are actually used for two things. One's for nomenclature, right? You want to tell somebody what kind of lysis or what kind of listhesis is this. And this other one is actually to know how we would plan a treatment protocol depending on that classification, which means it helps you plan a treatment protocol. So say if you're going to call up Amandeep and tell him that you got this case, which of these would you use now to describe that specific case to Amandeep? I mean, which of these classifications is most widely used by you in your practice now?
So if it's a straightforward degenerative low-grade spondylolisthesis, it would be very easy for me to use Wiltshire classification because that is the baseline with which he would understand as to what pathology it is. Unless I'm looking at something which is very high grade or somewhere where it is compensated, I wouldn't yet involve the SDSG classification. But for me to classify them into low grade and high grade, and secondly using the Wiltshire classification to just tell him as to what is the etiology behind it, maybe I would use the Wiltshire first. Yeah.
Great, thank you. So the fellows, somebody wants to ask some questions, otherwise I'll start picking somebody. You all decide. Shashi, you have a question? Is Naresh there? Question from the faculty? Anybody has a question? So if there's nobody to ask a question, I'll go ahead. So I want to talk about the Ferguson's view. It's an important X-ray that you take because most times when you do a AP X-ray, you're going to see something like this, gives you a probable suspicion of whether there is lysis. So what you do is ask your radio technician to drop, get a cordocephalic view, and most times it starts to show up the lysis. So it's an important view that you do in an AP, especially in your clinic ways where you're going to send it for radiology. A Ferguson's view has to be kept in mind. Okay, now I'm going to pick somebody. Pranav. Is Pranav there? Anoop. So you all need to be involved in this. Rishikesh. So nobody wants to be involved, huh? Okay, so Meridian is important. We all know that you split it into 4 halves. Each of them is actually broken up. And this one's actually the grade 3. Mind you, nowadays you find the CT and the MRI actually being graded by Meridian, but it's not supposed to be because Meridian is based completely on the X-ray and not the MR and the CT. So it's actually wrong when you get it graded in the MRI and CT. It's a standing X-ray that you use it for. So not for the MRIs and CTs. A few points here. Most times you see some patients with unilateral lysis. And when you see, you are given a few terms, what we call as the reverse Glipson's arch, which is actually seen in the Ferguson's view. There's also something that we call as a Kremer's French neckline, which actually means unilateral X-ray. That's how a normal pass looks. That's how an elongated pass looks. And therefore, this view is actually called the Kremer's French neckline. I didn't know what it was, but it actually means that there's one collar which is up there and one collar down there. So that's the one collar down, one collar up. So that's one view that you should remember. And the classical oblique views that was taken, mentioned by Rohan, which is aimed at finding out a unilateral lysis. You can see here, that one Scottish Terrier is without a collar, and that one is with a collar. So a Scottish Terrier dog with a collar wants to, all of you all want to, Rohan,
Yes, sir.
I'm audible.
Sir, right now you're audible now.
Go away. Is it?
Yeah, you just you won there like a couple of minutes ago.
So one of the
Yeah.
don't want to be involved. So area sign essential favorite question for most people. Scottish Terrier is with processes. Inferior articular process is actually the front leg. The hind leg is the contralateral inferior articular process. The face, so-called, is the transverse process. The ears actually is the superior articular process ipsilateral, and the tail is the superior articular process on the contralateral side. And that's where the break is, and that's where the eye or the pedicle is. Napoleon's hat sign, important also to keep in mind, because this is where in a spondyloptosis, there is a slip of the L5, and that reverses the Napoleon hat as we see it here. And that happens because of the slip of the L5. So these are certain points to remember radiologically. But the new things like Rohan introduced is, if I have sagittal balance and pelvic parameters coming in, my decision making gets far more streamlined. And that's where I would like to introduce Amandeep, Dr. Amandeep Gujral, to talk to us about the measurements and pelvic parameters involved in it. So I'll kind of stop sharing. And Amandeep, you can come in if you're there.
Yes, sir. So, just a second. So, yeah, can you see my screen now?
Yes, we can.
So, whenever we are discussing or considering the movements or biomechanics in the spine or any joint, it has to be considered in all three axes or plates. The lumbosacral region, it is a very peculiar region because it's a junctional region. So there are several joints which are associated with each other in a close proximity, all the facet joints, the SI joints, the hip joints, and they have a bearing on each other on how they function. Now, as Dr. Raghu showed in the initial slides, all listhesis X-rays don't look similar, but they are classified as listhesis. So if you look here as well, all these patients might be diagnosed with listhesis, but their posture or their alignment of the spine is not similar. So how is it different, and why it is important in your decision making to help you understand the disease and treat it properly? So we'll be starting with what the aim of the talk today would be. It would be to identify the different spinopelvic parameters. It would be also to identify what their relevance is and how do they impact in the patient's outcome. Now, for the it's a very broad topic and it's a very complex topic. So summing it up in 15 minutes would be next to impossible for me. So I'll be only focusing it on parameters which are associated with spondylolisthesis. So what we can do is we can club it in pelvic parameters and spinal parameters, where pelvic parameters would be pelvic tilt, sacral slope, pelvic incidence, and the slip angle. For the spinal parameters, we'll be considering the lumbar lordosis, thoracic kyphosis, and the global spinal alignment or the sagittal vertical axis. Mind you, there are many more parameters apart from these which are enumerated here. So what exactly is the pelvic tilt? So pelvic tilt is nothing but an angle which is formed from a vertical line drawn from the center of your femoral head and which is connecting with the midpoint of your S1 in superior end plate. The range is from 5 to 30 degrees with the average of around 12. Sacral slope is again a angle formed by the S1 superior plate with a horizontal line. that would be around 20 to 65 degrees with an average of 40 degrees. Now, both these parameters are flexible. Both these parameters are changeable. The only non-changeable or constant one is your pelvic incidence. Now, pelvic incidence, as you can see in the image on the left side, it is an angle between the perpendicular line, which is drawn from the midpoint of the upper end plate of S1, and a line connecting the midpoint of the end plate of the femoral rotation. So if you see this as the fulcrum, your femoral head, and just imagine the pelvis is moving around that fulcrum. So this is the angle which we mean by pelvic incidence. So this can range between 34 to 84 and an average of around 52, depending upon your race, your age, your sex and gender. Now, pelvic incidence is the sum of pelvic tilt and sacral slope. Pelvic incidence is morphologic. So as I already said, it's constant. It cannot be changed. But yes, pelvic tilt and sacral slope can be changed. Now, coming to lumbar parameters, thoracic kyphosis is a Cobb's angle drawn from T1 to T12, but most of the time T1 is not seen that clearly because of superimposition with your shoulders. So we can also consider T4. It ranges around 20 to 50 degrees. And lumbar lordosis is a Cobb's angle between the upper end plate of L1 and the upper end plate of S1. We can also bifurcate your lumbar lordosis in upper lumbar lordosis and lower lumbar lordosis. The easiest way is find the apex of a lumbar curve. The curve above the apex of a lumbar curve would be the upper lumbar curve. The one which is lower to the apex is the lower lumbar curve. The range is around 30 to 79, as I've already told you. There are different ways to see whether your spine is balanced or not. Usually the thumb rule, the easiest thumb rule which we can follow is lumbar lordosis should be equal to your pelvic incidence plus 9 degrees. This is a plus and minus as well for a mean value. Now, your sagittal vertical axis is the measurement of the horizontal distance between your C7 plumb line and a vertical line passing through the upper posterior edge of S1. Now, to get these measurements done, you have to get a standing scanogram done. These are digital ones, so you have those pre-made boxes over there where each box is around 5 centimeters. So it's very easy to calibrate it and calculate the actual SVA on those. So the mean value should be around 0.5 plus or minus 2.5%. Many articles say in elderly age groups, we can take this, we can make a laxity to this mean value as well. And it can be a little bit variation in that. As I already said, pelvic incidence lumbar lordosis is the easiest way to know about your spine alignment. And the correlation is significantly dependent on your pelvic tilt and the sagittal vertical axis. If there is a variation of less than 10 or more than 10 degrees, then we can tell it that it is a misaligned spine. Now, to understand why your mechanism or your biomechanics is important, you can look at these images over here. So this concept was very nicely demonstrated or illustrated by Raghuprasad. So where he is saying that as humans, we being bipedal, we are always a erect mammal. So upright position is the one where least energy is consumed. So he had divided it in the inside conus and the outside conus area, where if you're upright, that is the most biomechanically stable or sound position where there is least amount of pressures coming on your spine. If you're varying from your center of gravity, but still inside the conus, there should be further activation of erector spinae muscles to maintain your spine equilibrium, that you're not toppling over. But if your biomechanics or your SVA is more deranged than that and you're going outside the conus, then external supports like walking aids and would be required for mobilization. Now, this image would show us that where all bodies can try to compensate for this misalignment in the whole spine. So if you can see over here, it can start from the cervical one where hyperlordosis can happen if your SVA isn't positive to bring it black towards the center. There can be a reduction in the thoracic kyphosis and then hyperextension at the lumbar spine. When hyperextension is happening, a retrolisthesis can happen at the junctional level, which can cause a stenosis or a crankshaft effect over there. Understanding the pelvis mechanisms for compensation is a little bit tricky. So the right image, which you can see over here, that shows us that how it can be done. Now, as we have already discussed, your pelvic incidence is a fixed parameter. It cannot be changed. So if I want to correct this translational force to a compression force, what happens is the body tries to hyperextend your pelvis or go into a retroversion of your pelvis. Once that happens, automatically your pelvic tilt increases because you're tilting it and you are straightening up the sacral slope. So your sacral slope decreases. Now, this can be done only to an extent where the range of motion of your hip joint is restricted. Beyond that, if any more compensation has to be done, it is done at your knees and your ankle, where you will see a patient which is bending with your knee, bending at the knee joint just to keep himself upright and as much as possible close to the plumb line. Now, slip angle is something which we have not discussed till now. Now, slip angle is nothing but an angle which is formed between the lower plate of your proximal vertebra with the upper end plate of the distal vertebra. Now, this also many people describe it as a lumbar kyphosis. Now, lumbar lordosis is 60% because of your movement or the alignment at L4 and S1, and 40 to 50% because of your alignment of L5 and S1. So you can just imagine if you have a listhesis over there where it is grade 2 or grade 3 where it's stopping forward. So it exponentially changes your lumbar lordosis to a lumbar kyphosis, which you can see over here. So what do you mean by a balanced spine, a compensated balance, or an unbalanced spine? So a balanced spine is where your plumb line is where it should be within 5 centimeters of the desired areas. So it's not varying more than 5 centimeters. If the patient is still able to maintain the plumb line with compensation either at the lumbar level or at the pelvis level, we can say it's a compensated balanced spine. And if even after those compensation, the plumb line is more than 5 centimeters away from your normal, then it is an unbalanced spine. Now, if you'll come to the management part, we have discussed till now what are the scenarios of it, but now how does it impact our practice? Now, in last 30 years, there has been several articles discussing in details the relevance of your biomechanics of sagittal pelvic parameters. Many articles used to say 70 to 80% have satisfactory results. Even if you fix them in situ, you don't have to reduce all of them. But recently, as Dr. Raghu was also saying, there has been change in what protocols, and it's going more towards having a balanced spine than in situ fixation. Now, more than that, if you're looking at these articles are also saying that 70 to 80% have satisfactory results, whether you're fixing them in situ or you're doing reduction. But there is a significant difference if you subdivide your high grade or low grade listhesis into a balanced or an unbalanced pelvis group, where the balanced group patients perform much well in the quality of life and post-op pain management as compared to unbalanced pelvis. Now, in situ fixations, like in this example, many people would advocate, yes, this is a stable one. We can just do an in situ fixation for this. We don't have to reduce it. You can see over here, the pelvis is balanced. You have good lumbar lordosis, a good slope is there. Your pelvic incidence is also not too much. But there's always a risk of pseudoarthrosis, increase in slip progression, persistent cosmetic deformities, axial muscle spasms at dorsolumbar level, or having adjacent segment disease. This can also cause flat back if it's at multiple levels and you fix them in a kyphotic or a neutral spine. It is always better to balance those spines, as you can see over here in the pre-op and post-op ones. The pelvic incidence somewhat remains the same, but this value, the PILL, is the one which you should be focusing on. So you can see over here, it's around 20 degrees. So we were able to bring it to almost a very good lordosis over here. And it's a balanced spine, as you can see over here, instead of having a positive SVA balance in this. So points to take home is it's not only about the classification, but also about what is happening because of a surgery. So you shouldn't be focusing upon only fusing it, but what that fusion is going to have an effect on the compensatory mechanisms at the proximal or the distal level of your fusion. And this is where I'll end my talk, and now I'll open the floor for any questions or doubts. Thank you.
Thanks, Amandeep. So if you can stop sharing, and then I'll kind of come in. So questions? So Amandeep, somebody from the faculty, Rohan, you want to ask Amandeep something?
Not really, actually. Maybe if you could explain the nutcracker phenomenon a bit better, because that is where you have more shear and compensation as such. So what exactly happens at the nutcracker, like
So
type 1?
So what happens is, like, when the spine is going into an hyperextension, so that causes a stenosis at that level. So patients may start having a claudication effect and all. So there are two ways we can discuss it, the sharing one and yeah, so that is, yeah, so that is how it is.
So Amandeep, in your practice now, if you actually look at one of the questions that most fellows will have now is, how many of these you actually use in practice? Your pelvic parameters and overall spinal management. For example, one of the commonest thing asked is, how many of us actually do a whole spine standing X-ray? Do you use it as a protocol for all your lighting? You don't.
No, so if you'll ask
No.
me, I usually don't. Many people do advocate it, and if you'll go with the recent articles, everyone says that you should get a proper whole
Yes.
spine standing X-rays done. But
Yeah.
many centers don't have it, and so what I would suggest is getting standing X-rays where both the femoral heads are seen. You can also get the flexion and extension X-rays done to see how flexible it is. Because many times what happens is, if you get an erect X-rays, you feel it's grade 2 or grade 3, but on the MRI it's around grade 1. So that is an easier way to know whether it is a reducible kind of a listhesis or not.
Vishal, do you do the whole spine standing for all of your patients?
So we do want to do it now. I'm a very late entrant into the pelvic parameters, but now more and more as we do degen, it's useful to do them. It gives you an idea of how it's going to fare. Everybody says 70% do very well, but then the 30% who don't do really bad end up with multiple revisions, are never happy. So it's better to do a whole spine standing X-ray. Cost actually is a fraction of the surgical cost, but a revision would be very high. And the sagittal parameters, the more you read, the more they make sense. And I guess as a practice now, in all degen cases, pre-op, we have a full standing X-ray to get our alignment straight from skull to pelvis, which shows the two femoral heads properly aligned.
So very important point. I think as we go and as we look at only classifications and parameter, how important it is. Dr. Gupte, if I can get you in, will you agree with Vishal that you would do it for all your patients?
Yeah, I do agree with Vishal. Ideally, it should be done. But practically in my practice, I ask the people to get standing extension, flexion extension, not whole spine. But severe cases where I have doubt, I do ask for whole spine X-ray.
Yeah, Vishal.
So Raghu, the other thing is, it may not be practicable, or you may not have access to a full spine X-ray. So a couple of things we should always do in lumbosacral deformities as a rule is a slouch sitting lateral. It picks up very mild instabilities that usually are missed, because when you're doing a standing flexion extension, which is also another X-ray that we do because in obvious instability, it will show you if it's moving on activity. But in very subtle listhesis, you will not be able to pick them up unless you're doing a slouch sitting. Sitting is the most stressful position. And when slouch sitting, it picks up two things, the dorsolumbar kyphosis and also very subtle instabilities that may happen. And majority of the time people spend on sitting, is in sitting posture. It also changes your lumbar lordosis to a fair degree. So you get a fair idea of the pelvic parameters on a sitting slouch. And of course, as Dr. Gupte said, a standing flexion extension. A plain neutral standing lateral can also give you most of the pelvic parameters except for the sagittal balance, complete sagittal balance. So at least try to get on with that in your practice and do a slouch sitting to pick up, because you need, when your stabilizers, that the muscles are activated when you're standing, you may not have subtle listhesis showing. But when you're sitting and letting it go, that small slip can be picked up, which we pick up maybe 1 in every 20 or 30 cases where we thought, oh, why is he getting so much pain? And then you do a slouch sitting and you see, okay, this is the one.
Sure. So point taken. One other thing which I saw in recent literature is that they've stopped doing extensions. They see the neutral gives you almost as you want in extension. So that's one other thing that I saw. So going ahead, if I can go, pelvic parameters, few things to remember for the fellows. What's constant for every individual? Remember, it's the PI. The PI, you should remember, is a combination of the sacral slope with pelvic tilt. And most importantly, in a balanced pelvis, the sacral slope is high, trying to compensate, and the PT, pelvic tilt, is low. So there are some points that you can remember. But why is this patient here? Remember, this patient is not here for your pelvic tilt and pelvic incidence and so many other things that we've described, isn't it? He's here because he or she is here for low back, which is either instability at the pars, the facets, and the discs, the hamstring tightness, the reflex spasms that come in, or with or without compressive claudication or radiculopathy, and in certain scenarios, minimal neurodeficit. So this is what he's here for. And what you have to offer for successful treatment would mean resolve his back and leg symptoms so that he or she is back to functional activities of necessity. And if surgical, then you go back and look at the parameters to see to it that you maintain the lumbosacral and sacropelvic parameters, achieve fusion, shouldn't have implant failures, shouldn't lose your reduction, worse, shouldn't have pseudarthrosis. So to know what to do and how to manage individuals' cases of listhesis, I would love to call upon my friend and close pal, Vishal, to talk to us about management strategies, as he's going to talk to us and inform us. So Vishal, take over. I'll stop sharing my screen now.
Sorry.
No problem. Slideshow.
Yeah, okay. Yeah. Okay, hi. So this is one talk that I had taken in the 2022 BSS, but a good part of this talk has already been covered by Dr. Gala and Dr. Amandeep. Amandeep has given a great introduction to the pelvic parameters, which is very, very important. I'm going to run some, sorry. Okay, so very important that you are very sure that you're dealing with a spinal problem and not the others listed here, because anything that is not spinal, if you try to treat with this, it is going to be in a, sorry, I have a challenge here, sorry. Okay, yeah. So pelvic alignment, Amandeep has already covered this. So these are the 3 parameters that you should learn to do even on patients that you may not be planning to fix, so that you get into this thing. The greater sagittal balance, also very important, has been dealt in the previous talks. So you have to, somebody was asking about shear versus nutcracker. So what essentially happens in if you have used a nutcracker, it has one static arm and a sharp thing that cuts beetle nuts. So essentially when it goes down, it becomes a stable construct where they meet. So if you look at the right-hand side of your screen, the shear force, if you see the balance, it's in the nutcracker, the shear force, the arrow that's going, is going to cause this 5 to go on the S1 slope. So it's inherently stable. Whereas in a shear slope, it's in a shear condition, because the slope is on the higher side, it's going to slip forward. So I hope, Dr. Gala, that answers your question of what is a nutcracker versus a shear. That this on the right-hand side is a nutcracker. It's like an arkitta, which closes in and is inherently stable. So you need not reduce this kind of listhesis and they will still do well. So low PI and low SS, the nutcracker effect, have a low risk of progression. I'm sorry, I'm just going to try and reduce this thing. I'm not able to. And of course, the increase, one of the most common reasons for the red flag, as we say in parameters, is a high PI. If you have that, invariably you will have a higher risk of the listhesis progressing. If your slip angle is more than 55 degrees, it will progress. Females tend to progress more than males. Children, before the growth spurt, have a variable degree of, these are the ones to watch. The dysplastics will progress more than the spondylotics. So treatment. Fortunately, majority, including children and including early lysis, can be managed conservatively. It is not that you have to operate everything that is listhetic. In fact, degenerative conditions would be very, very stable. It's only the unstable ones where you need to go in. Up to 50% of listhesis, I think we just observed. Most of them, surprisingly, will be asymptomatic. My mother has a grade 2 listhesis and she's never complained of pain. She's 74th year of her life. Very active, walks 6 kilometers. So that's how active you can be. In children, they are a different kettle of fish. The lytic ones, where the progression happens with every growth spurt. These are the ones you need to keep looking at actively. Conservative till grade 2 is okay. But if it goes beyond grade 2 and they are asymptomatic, it doesn't matter. You need to go in because the global alignment will be so badly malaligned that the growth will be poor and they will progress into very bad pelvic parameters and quality of life later. Restriction of physical activity, and TLSO orthosis, not just an LS belt. If it is an orthosis, it has to be from top to bottom, which prevents the whole spinal column from giving the shear at the lowest segment. And of course, selective strengthening. Talk to your physio. Tell them this is not something that they do commonly. So you need to get your specific muscle groups strengthened for this. What is the goal of surgical treatment? Surgical treatment is to fuse the least possible of mobile segments to give the restoration of pelvic parameters as close to as possible. It is not a goal to get them back to normal and to try and get fusion without any extra instrumentation. Well, that's the goal. So indications, asymptomatic children up to grade 2, you can ignore. Symptomatic in, of course, once the percentage goes beyond 75% in adults, even if they're asymptomatic, that's grade 3, you have to get in. I'm talking about Meerding. But in children till grade 2, you can wait. After grade 2, even they're asymptomatic, it's time to intervene. And for, of course, all symptomatic patients who have failed to respond to conservative therapy and have a neurodeficit. So what is the operative treatment? I've included a nerve root, the decompression, though I don't do it anymore because we do it with a different, this thing. But the goal is to have neural decompression that and fusion of the affected segment. You can do it via various surgeries. I have several sites that have that will follow, that will show this thing. But what is the strategy that it comes to picking up what has to be done? So fusions definitely have a better outcome. There's a lot of literature supporting them versus conservative treatment, though a lot of people choose that. Posterolateral arthrodesis is not able to maintain in a dynamic listhesis the reduction so well as compared to interbody, so that is better. Though clinical outcomes are claimed to be better with either or. Those papers have some serious biases, but everybody should go and read up and go on that. So other interesting thing is with increased athletic activity, people hitting the gym, doing a lot of weight, we are seeing an increased level of lytic defects at L5 with no disc damage at a very young age. So initially, lytic repair was reserved for professional athletes in whom the career is at stake. And these were the ones who had their lysis repair in the initial stages. Lots of techniques for that, but essentially lysis repair is excision of the lysis autologous bone graft, and fusion with various devices that are available in the market. The easiest one is to put a pedicle screw in the pedicle, a hook on the lamina, and compress them. But are they useful? Yes. In well done orthodesis, they will work from 60 to 90% of the cases. A lot of new young patients, high demand gym buddies, want to try that also. I personally do not offer it to my patients unless they are athletes at a professional level. But increasingly, a lot of people are offering it to people who want to maintain a so-called gym-based healthy lifestyle. So spinal SDGC classification, as Amandeep was saying, is very, very helpful in deciding what you want to do, how much you want to reduce. If to go into great detail would be beyond the scope of this lecture, but you have to understand that the higher grade listhesis, it will be basically classified into a balanced and imbalanced pelvis. So what is a balanced pelvis? And what is this, like I said, retroverse pelvis, and the one on the left-hand side is a balanced pelvis. A balanced pelvis fusion without correction may hold, but a retroverse pelvis, if you don't correct it, you'll be in trouble. Like these are the 6 stages in HDCC classification. It is the recommendations that are, these are the recommendations of the classification. Type 4, any forced attempt may not be necessary, as is with type 5. But the type 6, the one on the right-hand side of the screen, this one, you need to make an attempt to go, even if required, from the front and then back, or from the back, front, back, to get it repaired and reduce it, because that deformity needs reduction. Otherwise, your surgical failure rates are going to be high. So ischemic spondylolisthesis is very important because it happens in very young. Degenerative is at the end of life, demands are very low. Ischemic spondylosis is in young patients, and they're going to have a high demand back. Unfortunately, what happens, these are the ones who usually get ignored when they are in grade 2 or and are progressing, and they progress to grade 3, 4, or to 5, and which puts an abnormal stress on the facet joints at the level, on the level above. It causes a stenosis and causes immense pain and neurology to the patient. So I would recommend this article. Every one of you should go through this article. This gives you a very comprehensive review of what should be done. Historically, we have seen, I'll go through some of the surgical x-rays for the interest of the fellows. Harrington rods were used to distract external fixators with gradual distraction, and then fusing them were used very much like how the principles of distraction that Elizarov and other external fixators use in tibia. Then, of course, the Bowman's reverse Bowman technique, where you would drill a hole through the sacrum into the L5, which in an optosis, put a fibula, or you can put a differential screw like an Herbert screw, and then go and fuse from 4 to S1. This is a very, very difficult surgery, should be reserved in skilled hands. Like I've seen Kshitij do a beautiful Bowman, reverse Bowman. I don't personally do that. These are another ones where they another distraction techniques where they distract and try to reduce as much as possible. These surgery, another one is to put a screw in L4, put a screw in S1, and then put a reduction screw in L5 and reduce it. And then fuse this and take the top screw out, put a cage inside. So these are the surgeries in which the L5 root needs to be decompressed right wide to its exit point, because as you try to reduce this, that root is going to get caught here and give you a deficit. So that's one tip if you believe in this technique. This is again, instead of using fibula, this is the screw that is used in a reverse Boltzmann procedure. Front and back, Dr. Dhar is one of the best guys for this surgery. I have seen him do a front spondylectomy, going back, putting a graft there, turning the patient back, and then reducing the 4/S1. He does it beautifully. This is an extremely morbid procedure. Thankfully, is required very, very rarely, in optosis only. And you would, in your lifetime, probably see a few of them. So this is this is how I personally prefer to manage. This is a young lady, 19-year-old, balanced spine. It is what is called SDGC 5 pelvis. Those are sacral parameters. That's an MRI. That's the level of stenosis you can see. I think we did this in 2021, Bombay Spine Society, KEM Hospital, as a live surgery. And we did minimal access. You can see this is the minimal access reduction, and that's what we got. This surgery is now more than 2.5 years old. Sandeep Sonone, who is the unit head for this, tells me now she's progressed to a good unit and doing well. I unfortunately could not see her after that, but this is possible. And this is another 36-year-old lady, again done via minimal access. Some of the tips and tricks that you should remember: most of these patients will have a very osteoporotic spine, especially in degenerative patients, and they will have a sclerotic S1. This sclerotic S1 is your friend. You should go to this area, burr through this, or use a sharp lenke, or in my case, I do use navigation because that gives it easy, and break this. You can see this is a grade 3 listhesis, and break through this because your screw will have the best purchase at this tip. This is all osteoporotic. Once you cannulate this, you have a fighting chance, or even if you don't have navigation under C-arm, use a nice lenke, go a little low on S1 and then get that corner, go through, break through the anterior cortex, feel that you're broken through the anterior cortex, and then put, I admire Dr. Goregaonkar when he puts an femur length measuring device into the sacrum and measures the length. I don't have that guts, but I then use the markings on the lenke and then put an adequate side screw inside. The most important part when you're doing any listhesis, low or high grade, is intradiscal work. You should have this set of curettes. These are domestically made, don't cost a bomb, and are easy to acquire. And this is a set from 6 millimeters wide and 2.5 millimeters thick to 16 millimeters wide and 7 millimeters thick. These are blunt-edged puka needles. These are the ones that work like a car jack. When you have a puncture tire, you want to lift your car, you gradually kind of raise it using a jack. So these are the, what I call the jack or the blunt puka chisels. The concept is, if you have a listhesis and the body has slipped over it, and this is, imagine this as the lower end of the top vertebra and this as the upper end of the top vertebra. As you distract them, like in a distal end radius, you use the ligaments to do the reduction. This annulus that is there on the side and the crumpled ALL and PLL will then tighten as you jack the disc space up and reduce this listhesis back to its original position. And once you have got it and distracted to an adequate space, you put in an adequate size cage. Suboptimal or small cage placements will ensure that your listhetic instrumentation will have a higher chance of failure. If you're lucky, it will unite. But a cage interbody part is the weight-bearing part. The pedicles where you peg your screws are the torque neutralizing. An engineering principle, weight bearing should be done by the compression part. So the front of the construct, that is the intradiscal space, should have an adequate size cage so that the weight bearing is proper. Of course, you have to prepare the end plates and put in adequate bone graft so that the cage weight bears and the screws neutralize the torque. So you have a stable construct. So chances of this failing are very high. We have done close to 103 high-grade listhesis now using minimal access over the past 12 years. We have one patient who failed. She was the one who needed to get back to look after her mother-in-law within 5 weeks of the surgery because the mother-in-law had a serious medical disorder. And over a period of 3 to 4 months, when she came up to show us, she had some pain. At 6 months, we saw that it was a fracture. We did a CT scan. Fortunately, in spite of the implant failure, the interbody work had united. But that was the only failure we got because we do it this way. We see to it that you can see my puka chisel is bang in the front. Don't do it. I do it because I can see what I'm doing with a microscope. You should be clearing. That's how much clearance and disc opening you have. This is a blunt puka that we are using. And then once you have trialed, you can see this is a cage that we have put in. So you put in a large cage inside, the reduction happens by, the cage does the reduction more halfway. The other half, you can also use Lordo's cages. You put in a small cage and open it up. So that will help you. I personally don't prefer to do it because that puts too much weight on the reduction device. And any device that has a movement component is weaker than a solid device. So we prefer to put solid cases. And also, you can see this is before locking of the rod. And on the right-hand side, I put in my rod and locked it. So this L5 screw, which was here, that's the gap. Now I pulled the L5 back using the rod. So this I'm confident of doing now because I release the disc completely. And internally, we do what the internal osteotomy of the opposite facet. And then we use this device to do reduction. These are all new reductions. MIS screws are now reduction based. So this makes it easy. Dr. Deshpande has also described a jig-based reduction in his article published in the Neurospine. You should go and read that. There are some steps you can use for open as well as in minimal access cases to get your reduction. The best thing, 90% of your cases are going to sit back and get okay by just positioning. But from grade 3, it will become grade 2. One of the hints what Dr. Amandeep was saying was to see the MRI. If the MRI is showing a patient with a grade 1 listhesis, but your X-ray shows grade 2 to 3, what essentially means it's a mobile dynamic listhesis and it will reduce fairly. If positioning does not, then what else to do? I've seen a lot of people extending the back and all. You can do it, but extending the back reduces your disc space. That can extending the legs, and the hips would cause the disc space to go down. So then it is challenging again to bring that up, but that's one way you can do. A bilateral facetectomy is another way of opening up the behind and then starting to distract the front. But this should be reserved as the last, not as the first option. A thorough disc preparation helps you by reducing 1 grade. A gradual distraction will help you reduce the 2nd grade. A right size cage will ensure to maintain these two, the reduction got by these 2 procedures. A Lordo's adequate bone graft will ensure that it heals well and early. A Lordo's rod will give you the final alignment and the sagittal lordosis that comes in. So these are the ways. So you can even do it for 2 levels. This is an MIS case in an 86-year-old with 2-level step ladder, osteoporotic bone. And that's what we use, dual thread screws. We did our intradiscal work thoroughly. And then this was the reduction. We didn't have to do much of the maneuvers. So plan your surgeries well. It's like building a building. Anybody can put a brick on top of the brick. But what is important is what is the plan? You pay the architect, you don't pay the mason. Because the architects decide, be the architect, plan your surgery. 90% of a listhesis surgery has happened here before your hands do it. 10% is execution. Remember that, it will be fine. Thank you.
So thanks, Vishal. That was extensive and elaborate. Obviously, you'll have to go off, Vishal.
Yes, I'm trying. Just 1 second. I'll just get off. Yeah. Okay.
So now the fellows, after 3 good talks, do you all have questions for the faculty? If not, then I'm going to go into the case studies. And that's why I wanted you all to, at this stage, ask. Okay, I'll ask you one, Vishal. Has there been any moment where you found bone graft insufficient in your MIS techniques as you've done over the period of time?
So sometimes you find it's inadequate, especially in revision cases. So where somebody has already done a wide laminectomy, a lot of times people knock off facets and leave it thinking the patient will be stable, which is actually not true. But that happens, and then the patient comes with an iatrogenic listhesis, which is very common, and we deal a couple every month. So these are the cases where we may not have adequate bone grafts. Yes.
So what's your backup? I mean, if BMP, yes, but if you don't have access, what could you do basically?
I don't believe that anything that opens the canal should have BMP. In my fellowship days, we have taken a drill through the foramen more because of excessive BMP being used. So BMP is for pseudoarthrosis. I would prefer to use it when I go anterior or in the oblique corridor. Posteriorly, you get enough bone graft from the facet. If you don't get it, then you go over the top where you take out the base of the spinous process, half of the opposite lamina and the lower part of the inferior facet on the other side. If you don't get it, I know for sure that Dr. Gupte goes and takes out through the same incision. You can take out through the, the PSIS, you can scoop out a lot of graft and put it there.
I've seen him do it.
But I would prefer to use allograft because that is another surgery, and sometimes you have patients who have more pain from the graft harvesting side. So I have access to allograft. I use allograft. You can use bone graft expanders, like you have Kronos or you have Mastergraft or any of the allografts that are available, and it usually works.
Any other questions for Vishal before I go on to the case? We've got an hour done, so an hour to go. So might as well start.
One small question to the both of you, like you and Vishal sir both. When you have elderly patients, like say 70-year-olds, and you plan on fusing them, sometimes what happens is when you put in those shavers, they're so sharp, and this is just for engaging into some discussion. You do not, when you try to size it, sometimes you have no control on grazing the central footprint of the end plate, where it kind of grazes too much, and then you may have to kind of readjust by putting in a larger cage. How do you prevent that, or are there any steps to kind of meticulously avoid that?
So Raghu, you want to try it before, or I'll do it?
No, Dr. Gupte is up there. So he's actually should be answering. That's for him and you. Dr. Gupte?
Okay.
Yeah.
Okay. See, what I follow, as I understood this thing, if there is a shaver you are using, see, you get a peel when you are scraping the end plate. You get a peel that this is the point beyond which I'm going to possibly damage the end plate. At this stage, I don't use sharp shavers. I use blunt puka, what he has shown, or golden puka by Metronics, and then try to distract it. And once I get an adequate distraction or adequate space, main thing is your disc-based preparation. You use a curate and remove whatever remaining disc material. That is the main thing. That's it.
So what I agree with Dr. Gupta. The only thing is I never use shavers anymore now, especially once the patient is beyond 50 years of age, sometimes 40. We use blunt puka chisel, so there's no question of scraping. Other thing is you should never go beyond 9. This is something that Neil Anand used to say, that you should never shave beyond 9. It's not required. You need a shaver at the entry. If you don't, I use a box chisel to make my entry for my cage. But if you don't have that, then you can use a shaver in the proximal part of the disc, this part where you're putting it in, to open it up. If you have to use up to 9, don't go beyond that. Ideally, use the blunt ones. Mahalakshmi Surgicals is the person who makes it for a few thousand rupees. A full set from 6 mm to 16 mm, you should invest in that. And use curates, but instead of cup curates, which can actually scoop out the soft bone, what I use now is an adaptation of the uterine curate. So uterine curates are made to scrape against the uterine wall. They are like a teardrop, and they are sharp, but they have a little flexibility. So when you put it on a soft bone, it will deform a little bit. So what it will do is it will just take away the soft cartilaginous plate, but it will not dig into the bone and take it out. So you should use that curates, and you should, it's to be done gently. You know the patient has poor bone quality, do it gently. In spite of this, there will be some patients where unfortunately the end plate will be compromised. One of the things you already said, you redirect your cage. Putting a large cage is not going to help if you're going to put it in a damaged end plate, because it's going to sink. It is going to sink, and your screws are from torque neutralizing going to be weight bearing, and they are going to become loose. So good thing is pack a lot of graft and then impact the cage again inside. That helps, and changing the direction, of course, helps.
Great. So now let's discuss a few cases with all that in the background. I would want all the faculties to keep their mics on. So I want some inputs as we go on from here. I can't change my slides are visible, right?
No, Raghu.
Is it visible now?
Yes, sir. Now it
is, no? Okay. So the first one. So we've got a 15-year-old budding fast bowler. He actually plays at the junior level. He's getting trained in one of the franchisee teams in the IPL. And he came with an acute back pain. The worst episode was 2 weeks ago, when he tried bowling a wee bit more than he would do in part of his training. Earlier, occasional some back pains he would have, and occasional some tingling numbness, which we feel clinically may not be of any significance because it was not very forthright from his. He did get better with some pain medications. His son, born to 2 anxious parents who want to see him probably make it up to Virat Kohli status. So already investigated and with some X-rays. So those are the X-rays at the AP and lateral, innocuous looking. And so then we got a Ferguson's, which probably did show something. And then we got the obliques. So Rohan, obliques, anything that comes out? I mean, it's very self.
Yeah, the collar, I mean, there is a pathology at the collar on one of the obliques, the right one, where you've pointed.
Correct. So there is one, and obviously that gives us an idea of lysis. And now, at this stage, would you do any more investigations? Because he's had a trial of medications. They're concerned for our parents. So would you go ahead and do an MRIs or CTs to confirm? Or how would you handle this case when he's seeing you for the first time in the OPD?
So probably the MR, yes, and some dynamic views just to see if there is any sort of instability maybe because of the lysis. Is there any asymmetry, maybe a standing AP, which may show that if there is any sort of coronal tilt, or is he compensating that? I don't know.
Okay, great. Vishal, would you do anything at this stage?
So this is a fresh injury. Obviously, for technical interest, you can do a SPECT scan to see if the lysis is fresh or not. But if it is an acute onset, I would rest this patient at this stage, put him in a long lordosis, orthosis, and ask him to walk around. He's allowed to walk around. He's not allowed to bend forward. He's definitely not allowed to do any bowling.
No. So Vishal will come to that. I'm talking about investigation. So
I'm telling you what I would do. This is my first and last investigation.
This is your last investigation. Fair enough.
By the time, this is the last investigation for the first 6 weeks. It's only after the first 6 weeks and he remains symptomatic, then the next stage starts. Because majority will heal at this stage.
Sure. So Amandeep, for you, MRI, CT, SPECT, which of these three are you going to do now? Vishal doesn't want to do anything till 6 weeks. What about you?
The MRI doesn't has any nerve-related compression. The X-rays are showing he has a pars fracture. We can get a CT scan done.
Okay.
That is maximum what I would say, but I agree with Dr. Vishal. Conservative is the way to go in such patients.
Anyway, so these are very, very, very highly stressed out parents. So they had gone ahead and done an MRI. So I'll pick only the relevant images here. The axial T1 shows a low signal at the right pars. The axial T2, you can see there very clear high signal. It's a edema around the pars. And bone marrow edema is seen with lysis at the pars in that parasagittal section here. Dr. Gupte, at this stage, what would you want to tell the parents?
No, I would tell them that there is a pathology there. There is something going on, probably because of the stress and trauma. And I would ask him to take rest for at least 6 weeks with orthosis, as whatever Vishal has suggested.
Vishal has said, okay. These guys even got a CT done because he's playing for a franchisee. So those guys are aggressive, and the CT documented the lysis on one side more than the other. And even the SPECT, like Vishal said, they've already done all that. So it shows that uptake. And we all know this is an acute thing that's happened. So to treat Rohan, rest. How long for you to rest?
Maybe 2 to 4 weeks. I mean, depending on his symptoms, 2 to 4 weeks.
And what's your criteria to say that, okay, this is rest is good enough? What would be your 1, 2, 3, 4 that you will think at to stop the rest cycle?
Maybe if he's having subsidence of his symptoms, say the VAS scale, if out of 10 his pain has subsided up to 2 out of 10, and if he's able,
then you would say, okay, time to.
Or maybe he can ambulate better.
Yeah. Okay.
So yeah.
Okay. So medications, what would you give Amandeep for this patient?
NSAIDs work quite well, anti-inflammatory drugs. Rest-wise, these injuries are quite common in fast bowlers. So as soon as they go back to their training and all, again the pain starts shooting up.
Precisely. So brace, Amandeep, what's your brace of choice for this guy?
Normal lumbar LS brace.
No, the normal LS, the one with the Velcros tied on, correct? Vishal, would you give anything different for him?
Yes, couple of things we do as standard for any young chap who comes with this injury. First, do a vitamin D level, because majority of them are vitamin D deprived. Nourish that first. Second thing is put them in a long brace that encompasses the thoracic cage and prevents rotation and extension of the back. Put them off practice. That does not mean they are off physical activity. They are allowed to walk. They are allowed to do lower extremity and hand exercises and some abdomen and chest, but they are not allowed to do any hip and pelvic movements. After 6 weeks, symptomatically they have improved. This is the time we would repeat the X-ray to see what is happening. Some will heal, some will show intense sclerosis around the fracture site, and some will remain like that. If their pain has gone down, this is the time we send them for their rehab, and the physio takes over from there. For the first 3 months, no rotation and forward bending. Rest of the physio is allowed. And if at 6 months they show union, they get back to full-fledged training. If at 3 to 6 months they do not show any union, but they still have no symptoms, then they get back to training again. We forget that our great cricketer icon, Sachin Tendulkar, has had a good 2-decade-long career with a lysis, which never healed. And of course, if they remain symptomatic, that's when the crookie crumbles. Then you do expect to check if it is still an active listhesis or it's gone cold. That's when you start discussing in symptomatic patients whether they want to choose alternative careers that are not so stressful on their back, or if they're insistent, then think about a past repair if the disc is good.
Elaborate. So now, Dr. Gupte, when will you start letting him play? These are anxious parents to know when they'll start to get him to play again. So if you go back to sport, when will you let them go back to training?
No, I will agree with Vishal, and when he's symptomatically okay and radiologically also okay, then only he'll be allowed to go back to active playing this.
So for both of you, as I understand, clinico-radiological evidence of improvement both matter to you. It wouldn't be just by clinical, correct? That's what I understand?
Yes.
It will be that. Okay. Calcium, vitamin D we discussed. When will you ask them to come back, Rohan, for a follow-up?
So 6 weeks and then 3 months, like every
6 weeks and 3 months. Okay. Now, if you come out with an idea, because these guys have enough access to the internet, and if they ask you, Amandeep, can we have a pars injection? What would be your response be?
In acute phase, yes, definitely that can be tried. If the pain is too severe. I personally don't do it.
Yeah.
I personally don't do it, but I know people across Bombay who do it. And yes, that is an option for controlling the acute pain.
So Vishal, would you advocate? Would you, in your practice, advocate and consider pars injection? Vishal?
Sorry, can you hear me now?
Yeah.
So somebody who's not progressing, has been static for a very long time, is still symptomatic occasionally, may be a candidate for a pars injection, who has a very silent SPECT image. These are the guys I would inject. Maybe before going in for a surgical thing, we might give an injection to check that A, the pain is coming from there and never nowhere else. And second thing is, sometimes the inflammation dies down and they're happy with it. They can train better.
So one, you're saying it would be probably to confirm that it's the pars that's causing it and probably give him some relief. Okay, now the first question that they're going to ask you, Amandeep, is, uski career ko to affect nahi karega. This is a common question that they're going to ask. What would be your answer at this stage? Because they are those concerned parents.
Concern is one thing, and just to placate them, we cannot change our answer. So definitely,
So
he's a
what
pass
would you
bowler,
say? Yeah.
it is going to affect his career.
Absolutely. So the conviction, I think, to say that we'll watch as it goes and there could be a problem in the future is the way you would be, right? That's what you're trying to tell me, basically.
Yes, sir.
Okay. So pars repair was discussed. Consideration for the fellows to consider this. Failed 6 months conservative trial, age less than 20, pure lysis, and about a possible modified Furman grade 1 to 3 is what's suggested. Dr. Gupte, how many have you done in your career, pars repairs?
Never.
Not done. Vishal?
So in my fellowship days, I have seen 2. And in my private practice, fortunately, none, because whatever and whoever has come has so far, touchwood, improved with just conservative management. So we are
wonderful. So the need's been very minimal. Rohan, do you want to differ? Have you had the opportunity to either see or do more?
No, sir. Absolutely no.
So I've had actually one. Let me be clear, and that's the one I have. Just the one. Don't ask me why, but I think,
so
indications were in.
Add to this, Raghu, I am actually against repairing the pars. because there is only one AO implant which they have since withdrawn, which makes some biomechanical sense.
Absolutely.
Medical seeking and putting the hook is very, very invasive. That usually screws up the athlete's life.
Yeah.
You've done is a very, very good minimal access one, but again, the interbody, the defect that needs to be curated and the graft that needs to be put, and it has to be proper. And usually all past repairs so far I have seen, none of them have returned to high performance athletic activity.
Sure. So this one, interestingly,
Raghu,
yeah, yes.
Yeah. In Korea, during my fellowship days, my boss used to do this quite regularly. And he used to do it percutaneous, pass a guide wire and pass a cannulated 3.5 mm screws.
Correct.
That's what. Yeah, but I don't know about the result. And
absolutely. So this one, interestingly, probably got better. And my argument is he would have got better anyway in the natural history. So I'm here standing up for it and saying probably the role is minimal. And why is it? It's enough in literature. I think, as Vishal said, that if you look at these past injuries and follow them up and do CTs at about 12 to 16 weeks, this is not mine. This is a classical type 2C that they have healed and shown. You can see the actual CTs which have healed very well. So that's the message we want to give, that there is so much in literature but need not be applicable always. And that these are the ones which just need some, if I might say, tender loving care to the parents more than the kid, and they fall in place. Any points to be added, or I can go to the next one?
I think we should go to the next one.
So the next one. So a 26-year-old teacher, axial back pain, mechanical in nature, claudication, but she's had a sudden right leg aggravation over the last 4 months, temporary relief, repetitive, she has to go off work from school and disability there, significant need for pain medications. We've ruled out the red and yellow. And there's nothing much except an extension catch that was seen. And that is the X-rays. So Amandeep, you want to just go quickly with the X-rays?
She has a lytic listhesis at L5 S1. It's quite minor, grade 1.
Grade 1, yes.
The patient is complaining of radicular pain, so an MRI is warranted in this patient.
Okay, so that's the slip. So it states at grade 1. And a few things which look in this lady specifically was this little rotation of the spinous processes, which is talked about. I think some Ramanathan or Ramalingam. You should also look for in the X-rays for the fellows, there is an associated myelodysplasia, because that's important to keep. And like Amandeep said, we got MRs. I've just put the relevant ones there. Rohan, on the MRIs?
I mean, yeah, the disc there is kind of degenerating much quicker as compared to the others, because the others look well hydrated.
Correct.
This one doesn't. And the facets are, and you can see the pseudo translation, I mean, a slight translation at the axials, and the facets are also degenerating much quicker.
Sure, correct. So there's that pseudo bulge, that is the fascial arthropathy. The Furman's obviously is, but what came out was this foraminal disc on the right, which kind of matched with why she's had this sudden aggravation recently. Facetal tropism, which is well documented. Any role for CT? Do you do CTs often, Vishal, for these kind of patients?
No, I don't.
You don't? Okay. So unfortunately, we had one, which was already done by the time. The points to look for in the CT is the classical wide canal sign. These are things I want the fellows to remember, that that's the normal canal size and there is this sudden widening. A few things you look for is whether there is posterior laminar defects. Look at the integrity and the size of the L5 pedicles, because that's one of your big anchors to work on. Look at the sclerosis there. And also, for that matter, like you can see here, the pedicular lysis is to be kept in mind, and see how narrow this one is. So if you keep all this in mind, it sets a plan for your treatment. So what next? We took a lateral whole spine view. So for the spinal balance, wasn't remarkable, and that's the X-rays now. So Rohan, what now for this lady? 4 months aggravation of right leg pain with chronic low back disabling pain, needing 3 days a week of pain medications.
So here I would again, try to identify whether the back pain is truly mechanical or is there any psychosomatic component. Because
so how would you differentiate? So if you kept the red flags off and the yellow flags off, so that's done. I have told you at the beginning. So that's done. What else?
More importantly, if the symptoms of leg pain equal to that of the back pain, this would warrant a fusion for me. Maybe
Okay.
prior to this, I would do a dynamic X-ray just to
Okay.
see as to how much the degree of slip, whether it is worsening or not.
Okay.
Because the CT represents, a normal alignment, to be honest. So that's a supine film. And when she's standing, there is some amount of instability because you have a grade 1 slip on standing, which
Sure.
is kind of reducing completely on supine. So I don't know. I may offer fusion. Yes, fusion for me.
Okay. So, Vishal, conservative surgical at this stage?
Sorry, I just mean the part of how long has she been and has she done
So
any?
she's 1 year with back pain, 3
Hmm.
days a week of pain medications in the last 3 months, temporarily gets better. But the key thing that she's come for is this right leg pain, which is aggravated over the last 4 months.
So she has a foraminal disc. She has obviously lytic listhesis. I would add a flexion extension sitting view to this to see for whether it's a dynamic listhesis.
Sure.
If either or, if conservative management has failed, there is a foraminal disc. And it's a degenerated disc with, if you can see, the facets are grossly degenerated. This would be a straightforward surgical case for me.
Okay, so then she went through the needful, but what actually mattered was she had a little pass and transforaminal root block, which worked quite well, 70-80% improvement for at least 2 to 3 months, but then came back the recurrence. So she came back nearly almost the same or worse. At this stage, the options. Amandeep, pars repair for her?
So I do interbody.
You will do an interbody. So straight away, no pass. Message
Nothing,
to the
sir. No
fellows.
beating around the bush directly.
No beating around with the bush. If I ask for that matter, Rohan, we know degenerative has all these talks about posterolateral and interbody and ALIF. What's the downside of doing a posterolateral fusion for her? If you could put points down straight away.
Yeah, first is you have to restore the disc space here.
Correct.
Alpha S1 will give you again, that lordosis which she requires. Second is the shear. So basically, if you don't fuse anteriorly, the chances of failure are higher because you've not reconstructed anything anteriorly, and purely depending on this for a posterolateral fusion is, I don't know. I may not go. So there was this nice paper by Madan and Boyer back in the days, I think in 2002, but still they eventually said that a global fusion is much more superior than only
Absolutely. So what are the downsides of posterolateral fusion in lytic listhesis? Mind you, these are the words. Inadequate fusion because there is this big conglomerate of bone, but you don't know if it fuses. This continues to degenerate because you've not achieved fusion in that segment. It's a non-load bearing sharing, non-load sharing fusion, doesn't work. There is lack of evidence, like I said, a semi-rigid stabilization, a little implant dependent. So if your implant holds, your fusion holds. This is actually an important slide, probably also because it's so difficult to achieve fusion. The effort for the surgeon is so much more. And Vishal and Dr. Gupte will know, this is one of my follow-ups of Dr. K.V. Chobal's operated patient, a posterolateral fusion done intertransverse, so beautifully done that she had no symptoms from the lower back, mind you. She finished almost 36 years post-op. So is it also because we are not doing, we are not probably patient enough to achieve fusion? So it's just to put this specific slide, which I've stored in my memory always.
Raghu, let me add this. I've worked with Dr. Chaudhary for
I know. That's why I specifically mentioned.
Yeah. I was his junior most houseman.
I know.
But I still remember that his, graft made preparation was
brilliant. I know. And look at this, Dr. Gupte and Vishal and everybody, how beautifully it's been done. Okay. Substrate not too good. Yeah, you have these non-specific transverse processes, which doesn't do justice. So we don't know. And too much of traumatic paraspinal musculature, cutting across. MIS could save it, but where is the graft then? So it's only an adjuvant now. The another case is one of my own, which, we revised where you could see how the fusion just didn't work, cascading spine, and we had to revise. Now, one point here, Vishal, what about interbody fusion with just the graft, not put in a cage? Downsides?
So to put in the graft, you will either have to retract the nerve root and access the disc space, or you have to remove the facet. If you remove one side facet, the instability will be gross. Here, there is a bilateral lysis. So you're not going to have any torque limitation at disc space. So a stable construct leads to better fusion. So if you go into the analysis of posterolateral and instrumented versus uninstrumented fusion, the only advantage they said of an instrumented fusion was a higher fusion rate compared to uninstrumented. So uninstrumented, the fusion rate was somewhere in the 60s, whereas instrumented, the fusion rate was above 90s. So significant fusion can be achieved if it was, say, a non-lytic degenerative grade 1 listhesis. You can still put interbody device, but if you're operating and you're going to go inside enough into the disc space,
Why
then
not put in a cage?
enough,
Sorry? Why not put in a cage too? That's what you're trying to tell us, right?
I wouldn't say a cage, but I would definitely put screws. When you say instrumented, it includes screws as well as cages. So now putting in cages adds to the cost, but cages also restore the interbody height, which is very important in a stable construct, because the front is the weight-bearing construct. If you just put graft and expect the screws to do the load bearing, they will do it, but there is a higher chance of that failing. When you put a cage in the front, Indian cage can come for as little as 2,000 to 3,000 rupees. That gives you that additional security.
Sure. So point noted, Vishal. So this one is one done elsewhere, but this was done with some chip lift graft, which is there in the operating notes, held on for about 8 to 10 months and then gave away. So this is exactly what we are all trying to say, that the reconstruction anteriorly is so much important because the load bearing segment is there. What did we do for this lady? We did a conventional T-lift. I know this is an open T-lift, so it was in the MIS. This is an old one. Good 7-year post-op, which we have. So let's go ahead.
So other thing, Raghu, just one
Yes.
comment in what
Sure.
this case was. So if we were to do just an transverse fusion, we would not be restoring the foramen.
Discal height, foraminal height, yes.
And you had a disc popping in the foramen. The stenosis was actually an foraminal and lateral recess stenosis, which would not have been addressed. So the patient could have had persistent symptoms on back or some claudication. So interbody in her was mandatory.
Absolutely. So we
In
go
fact,
to the...
in fact, this patient from day one, I would think of only and only minimal invasive T-lift.
Correct.
That too from the approach from the right side, because foraminal disc is on the right side.
On the right side, absolutely.
Yeah.
Absolutely. So now the next one, 42-year-old, software professional, thyroid, obese, leg more than the back, left leg a little predominant, disability, and failed conservative trial. So obviously, we're not going to be talking about that. That's the MR, and that's actually the CT cuts. I just picked relevant ones. I think there is, again, a foraminal disc on one side. Rohan, at this stage?
Sir, I would operate this. There is no
way. Okay, so she's ready for surgery. So what's your approach for surgery? If you can tell me 1, 2, 3, 4, that's the surgery and a few steps that you would go ahead and do.
Unless I mean, I am not sure whether this is a united thing based on the CT. I mean, if this still moves, or if there is still some amount of segmental kyphosis which is demonstrated on say dynamic views, I would consider. But if it is
not fused, I'm telling you it's not fused.
So that flexion extension, Rohan had a movement.
So I think there is 2 levels of lysis in this patient, or it's only 1 level?
It's 1 level lysis, as I think was...
Because this is S1, the one which you had shown previously, that was L4-5. The axial cuts are for
5
S1.
on which L4 has moved forward. I think.
Yeah, the lower one is also looking like...
So I don't think it was reported, if I remember correct. I think this was just that level,
So, sir, it's the last motion segment. I would offer an interbody, but again, the obese patient, too much of muscle retraction, again, putting in a screws and medializing them and getting that, there's a lot of struggle. So here I would actually put in MIS screws, to be honest.
So Dr. Gupte and the masters, Dr. Vishal, obesity and so many other criteria. Can you tell me MIS is straight 4 or 5 things that it stands over in such a patient, basically?
First thing, I would get her dynamic views to know how much is the mobile.
Okay.
Then I'll plan my surgery accordingly.
Okay.
On table, in operation table, first thing is positioning, whether it is reducing how much. If it is really stiff, I would do absolutely stiff. I would do bilateral fasciectomy to make it more mobile.
Okay.
Proper disc preparation. In this case, I will not use sextant screws, sextant system. I'll use tower.
Okay.
Yeah.
Vishal?
Yeah, so to add to Dr. Gupte's view, obese patients definitely MIS because the MIS incision does not change depending on the patient's size, whereas an open surgery, it would definitely change. Second thing is, yes, reduction. I would do a proper hyperextended patient to hyperextend and give the lordosis. So that reduces a bit of the reduction. So a lot of people flex the patient to and think that they will be able to put a cage easily. Ideally, you should use your position to restore some of the lordosis, and the rest of the job you can do it easily through that. What Dr. Gupte says, there's definitely not an arc-based reduction device. We would use reduction screws or towers that are available now. Do a lot of interbody. In my case, I would dock from the most symptomatic side, do a facetectomy. Before I do the intradiscal work in this patient, I will do over-the-top decompression to give the neural structures that little space that is required when you're manipulating that area. Also, while doing the over-the-top decompression, I'll take a chisel, break through the opposite lamina, and break through the opposite facet joint's inferior surface. So that internal facetectomy also gives you some amount of release. We are in the process of publication of in one of the places. If this does not release, we do an internal opposite side facetectomy. So typically, when you're doing over-the-top decompression, one of the complications that happens in an over-the-top decompression is that while drilling the opposite side, if you drill the pars too much, you cause a pathological fracture there. So this complication we are using as an advantage by making an opposite side pars, use a chisel to go through the opposite pars or a drill, break it. So it's an opposite side facetectomy. Before doing that, you ensure that the inside part of the opposite side facet has been removed and decompressed so that when you break the facet and the bones kind of come into alignment, you don't have a foramen that has become very tight and causes a neurodeficit there. Then you do the intradiscal work, distract that place, put in a large cage and like a routine case. This is the standard for this kind of cases.
And use of L4 screw, how often?
Sorry?
What defines it? L4 screw, how often and what defines your need?
L4 screw for what?
Which means if you're doing an L5S1, and let's presume you want to use the upper one, and then eventually, like you showed in one of your slides, that you take that screw off. What defines that?
So that is not my slide. I've borrowed that slide.
No,
I
but
never use it. I never use it.
So you don't. That's what I'm asking.
No.
Dr. Gupte, would you use it?
No, Raghu,
never.
I have not finished. I have not finished. Sorry, Dr.
Okay.
Gupte. I don't want to cut off, but what I want to say is using of a reduction screw for a listhesis is a wrong practice. That is where failures occur.
Yeah.
If you are going to use your screw to reduce in an elderly patient who may or may not have good bone stock, you're already putting pressure and making grounds for your failure. That's why high-grade listhesis was so problematic in the classical and legacy-based surgeons. You have to understand that it is an anterior problem, needs to be handled anteriorly first, and then use screws only as a neutralization device.
Absolutely.
Never put a reduction screw.
Absolutely. Dr. Gupte, you want to come in? Any points?
Yeah, no, I have never used L4 screws.
Screw at all. Okay, okay. Because there are a lot of people who mention it. That's why I wanted to know whether you need to.
So
Okay.
One question for Dr. Vishal. In obese patients, when you're using a tube, do you take another incision for the docking of the tube or use the same one for the screws as well? Because many times they don't align together.
Sorry, can you come again? When an obese
for the docking of your tube and for the incisions for your screws on the ipsilateral side.
That depends. So that depends. So if it's a very fat patient, I will go more laterally to get a medialized screws. Nowadays, I only use O-arm. So I can go 7-8 centimeters lateral. So then I would do that. Now, if somebody is very, very cosmetically conscious, you can still use the same superficial incision. Release at the subacute and deep fascia plane. Take it back and put your lateral screws. I have stopped using the sextant device because I believe it's completely outdated. So now I use only reduction towers. So that is very easy to go through the same incision. You don't need to make a separate one anymore. We used to do it for some time, then we realized you can still manage the same screws through the same thing. You just have to release it a bit. We use it like the Koreans do. The Koreans actually go through the deep fascia and subacute plane and then put the screws from the side. So that's what it goes.
So this was the time that I wasn't doing too many MISs. So we had this conventional technique that we use and very good follow-up thereafter. So when we started this topic discussion in the BSS with Amit and Gautam, there was a clear idea that we should have one discussion of degenerative listhesis, but that's something the fellows would want to know. So I'm putting up a case of a 77-year-old diabetic, retired army officer, chronic low back pain from the age of 30 when he was in service, minimal back pain. Now, some 2 or 3 pain medications in a month, bilateral leg claudication, less than 5 minutes walking ability, significantly disabled, typical army man, a glass of whiskey every night he enjoys, occasional smoker, peripheral pulsations were normal, right L5 deficit grade 3 since 2 months. So he started noticing his chappals were going off in the last 2 months. He's had some prosthetic surgery. He's better with pain every time pregabalin is taken. An epidural was done 2 years ago with some 4 months benefit. Though he's had no medication since the last 6 months. To complete, neurodiagnostic studies talked about compressive radiculopathy and not so much neuropathy. And we've done it to differentiate the two. X-ray is Amandeep.
These are standing X-rays.
Standing X-rays.
You don't have a normal routine erect one.
Oh, and so I don't. I don't.
No, because at 77, we have to understand that they don't have too much of potential of what I would say compensating for a stiff spine. So
Correct.
you actually have to see how much you are going to fuse and whether a fusion is required or not.
Correct. So X-rays, quick one.
To me, it looks stable. He has 2 level of he has degenerative disease at L4, 5, L5, S1, L4, L3, 4, more probably not confirmed. We'll get an MRI done.
So sure. Here's the MRI
Yeah.
for you.
Yeah. So as I said, it's 3 level, 3, 4, 4, 5, 5, S1. Can I have
So
the
that-
axial
Yeah,
as well?
so axials. There is a naming issue. I mean, the level.
Yeah.
So it's 2, 3, 3, 4, 4, 5. So let's keep it at that.
Yes. The proximal most looks fine to me. I think we can consider it as a 2-level disease, 3, 4, 4, 5.
Okay.
So I would prefer to not fuse all the 3 levels. 2 levels should work well. The thing is, if I can get away with decompressing without causing an instability by removing too much of a facet, I will prefer doing a decompression alone.
Yeah.
And if at all,
MIS open.
open.
Dr. Gupte.
This case, I would do MIS Philip at L4-5 and maybe just micro decompression, tubular micro decompression at L5-S1. That's it.
What makes you consider fusion at the 4-5?
There is some amount of instability. And if I'm going to decompress, I'm going to add to it.
So for me, Rohan, if you look at the MR morphological changes, facet fluid, synovial cyst, interspinous fluid, facetal joint arthropathy, and vacuum sign, which of these would you give the most priority in terms of defining instability?
Fusion.
A facet, joint hypertrophy, and facet fluid for me.
Those two are the ones. Vishal?
And vacuum as well. Maybe the third one. Yeah. I mean.
So for me, mandatory full facets, that is a facet with effusion, and all synovial cysts are a straight indication for fusion. And hypertrophic, arthritic, hypertrophic, dry facet, but if there is not too much of back pain, I may leave it alone because that is dry and stable. It is the one filled with fluid I'll be very wary of in this patient. The 4-5, actually, if you see inflection extension is a dynamic instability. The 5S1 is stenos. The 4-5 facets are very, very vertical. I would be, trophism is where it is an unstable situation. So 4-5 needs a fusion. He's 70-year-old, so just maybe a 4-5 T-lift and a 5S1 also, because if you're going in, if there is a 3-4 and a 4-5, both which are degenerate, a 4-5 main, with a mild 3-4 and a mild L5S1, I would be very, very scared of the L5S1 because that's where all the movement is going to go. So this is already arthritic and stenotic. So I would fuse L4-5 and L5S1, minimal access, and 3-4 is okay. I'll leave it.
So the fellows and the residents, this was one point of contention. If you look at it, all 3 of us had different approaches, and this is where the whole confusion starts. So what did I do? This is actually his post-op with his doggy there. And I just did a open decompression, mind you. I think something like Amandeep said. Now, why are we talking this? I know Vishal mentioned this offhand, that if if you go and look at these journals, and most of us would say, "Arey, wo to ek medicine ka journal mein se aaya hai," but what they came out and said was decompression surgery plus fusion surgery did not result in better outcomes. This is what literature said. And degenerative grade 1 spondylolisthesis can get away with just decompression. Also, if you go by literature, till recent, I'm saying till recent, it was ambiguous. Some of them said isolated decompression doesn't cause any postoperative destabilization. Some said it could destabilize radiologically, but it doesn't alter the function. And some said, no way, the moment there is instability, it can give a negative impact. So initially, before 2016, mind you, this was much before this case of mine, Blumenthal was the first one who got about a meta-analysis and said, consider 3 things: preoperative slippage more than 2 mm, disc height more than 6.5 mm, and excessive joint facetal sagittal orientation. If you have all 3, then a good 75% chance that you have a poor result. He later added the sagittal spinal misalignment to it. So this was what was available in 2016 and 17. And if I extrapolate that in this specific case, I know the red flag was the more than 2 mm slippage, which was pre-existing, mind you. Disc height was very well settled, and excessive joint facetal orientation wasn't there in my eyes, though I think Vishal said no. And that's why probably it worked. So it's a retrospective thought, mind you. And without a doubt, at that time, we weren't looking at sagittal spinal malalignment. The 2023 literature goes one step forward, and this is what the best that we have today. It looks at segmental instability. It looks at where you're going to decompress. It looks at sagittal alignment and looks at clinical presentation. And in that context, Kirshner's article in 2018 said, you might have a static vertebral slippage, but restabilization in degenerative listhesis is known. You have to treat these 2 axials differently, and that's the message we want to give you. For example, this one, as compared to that one, as was said, significant facetal effusion, facetal arthropathy combined could be far more unstable than what you have here. That's also important. And whether you're going to do the central lateral recess of foramen, how extensive is going to be a decompression? Because ultimately, patients come for claudication symptoms to you. Over above this, you're going to add the sagittal balance, which is the new thing here. But you cannot take away what's clinically relevant. That time that you spend with the patient, is back pain a part of his activities of daily living? Is his leg and back component equal or more on either side? What is his need for pain medications for the back pain specifically? And what are his disabilities in his activities of daily living? This question and this proper preoperative counseling is warranted, and mind you, involve the patient in the decision making. It's so much important that you don't stay radiological. The patient's the final one who's going to have treatment. You can add age, comorbidities, what job profile. If you have a Mathadi Kamgar who lifts about 80 kilos weight on his head, what practice setting are you? You're sitting in some remote part of the country. Not that it should alter your treatment. What culture you are from? I mean, in the US, you could have an L4-5 fusion done, and a borderline L3-4 would be handled for later, for whatever the cultural reasons. They would say, we'll come back for it later. It doesn't work in India, so they don't want to come back for it again and again. And the socioeconomics. All these are relative determinants, but important. Any other points before I go to my last case from the faculty on this specific case?
Just one point. If you had to do this X-ray in today's era with all the sagittal balance and all, the problem, I mean, actually that stresses the importance of just pure standing lateral LS spine X-rays.
Yes.
Because you can have like a very high PI, but the lordosis is 30, and just if we go for a random PLF, the problem is not the work done there, but because it will create now a relative kyphotic place for the other 2 which are above and below.
Segments. So I think what Rohan's coming up is saying there are compensatory mechanisms that are happening which are actually helping the patient. You know, there is a scenario like you have people who come and say, I have a less arch, medial arch of the foot, and they put in some what we call as, the cushions that we get, and they actually become worse because for so many years they've been well compensated, isn't it? That's what you're trying to say.
So basically, this X-ray has a low-grade listhesis with a nutcracker.
Yeah.
This is a classical nutcracker where an extension is actually stabilizing. You can see the X-ray. He has done flexion extension. Even the flexion, it's not toppling over as a shear.
Yeah.
If you were to extrapolate it to say, I'm not saying this is not an exactly L5 S1, but you are used as if you use the same principles, this is a very stable L4 L4-5 by the nutcracker classification if it was to be applied here.
Correct. Okay.
I mean,
So the last, sorry. Anybody
Yes,
wants?
No, go ahead. Yeah.
Yeah. So the last case for me, she is a homemaker, 4 years postmenopausal, long-standing back pain, increase in the last year, pain medications almost 3 days a week in the last 6 months. She's very clear. The one thing that gave her pain was bending forwards. And every time she would do it to do certain chores, she would struggle. She's been claudicating less than 10 minutes. She's had temporary benefits as all treatment. Physiotherapy did reduce the back. She was also clear that whenever she wore the belt, she would actually feel better. Back was almost equal to the leg and there were no comorbidities. Nothing much in the history, and therefore this is the X-ray that she came with. Rohan, X-rays?
Sir, subtle grade 1 at L4-5 and some amount of coronal tilt on AP, I think, if it is time.
So then we looked at the movements. They were good, but there has an extension catch. SLRs were unremarkable, no great tenderness. Pulsations normal, jerks unremarkable, and neurology normal. And the hips and SI joints were done. So she came with an MRI. Amandeep?
So the pain you're saying claudication is on both the sides or only
Both
one leg?
sides, almost equal. Back almost equal to the leg when you ask them that question. And disabling back in forward bending.
Okay. No, because she has a lateral and sort of a foraminal stenosis on both the sides. Now, clinically, she is getting better with physio and additional support, but activities are still restricted. So I'll consult the patient and see whether we can just try to nudge her towards a conservative one and see if she's okay with that much amount of recovery, good enough. Otherwise, go in for a surgical option. Pain management as a middle path regime. So basically, it's just choice of the patient, how much severely is disabled she is.
One test you would do in this lady?
BMD, 100%.
One test?
Bone mineral density.
I think BMD for such cases is something like a overkill. Matlab, I don't think a single level fixation in a balanced spine and a good height disc, there is any injury of causing a end plate damage or the whole screws not holding. So I'm not too worried on that part. But one thing, if we'll see on the axial cuts over here, just see the kind of the muscle atrophy in the paraspinal muscles.
Sure.
So I feel it's a physical deconditioning of the muscles more in play than a compression of the nerves which is causing the complaints.
Vishal, any specific investigations for you for this lady apart from what we have?
I'm very. Amandeep has picked it up brilliantly. I'm very worried with that muscle. It's completely white. It's like a 90-year-old's back. And she is probably symptomatic because those muscles aren't doing any supportive work. That's why a brace helps her. My problem is doing a surgery, you will probably restore the height and fix the 4-5. But that kind of muscle in a 50-year-old warrants serious investigations into her general well-being.
Sure. So would you actually defer a surgery and get her to do more rehab and then come back to you?
If she does not have a neuro deficit and if she's
wait for it
with a brace, I'll give her a brace for some time, though brace is counterproductive for that. But this is severe sarcopenia. This is grade 4 plus. So she needs to get into a proper diet counseling, get high protein diet. She needs to do some good weight bearing, high impact activity, because concentrate on her course, spend 3 to 6 months. Mind you, this is only to be done if there is no neuro deficit.
Absolutely no neuro deficit. So I agree with you. Dr. Gupte?
Yeah. I just agree with Vishal, but I add one thing, that there is a facet fullness on right side at 845. You can see that.
Yes.
So I will tell her that we do the conservative rehab, muscle building exercises and everything. Maybe I may add epidural or facet joint injection.
Okay.
Yeah, that will help her do her exercises better, buy us some time to improve. I agree totally.
So a whole spine sequence was done. I think for the fellows, always remember that's more or less mandatory now. But the flexion extensions.
Wow.
So this was one of my own case, a staff nurse's mother, innocuous looking MR in the, I mean, I know there are things to talk about, sir, but suddenly it gave me a complete picture. And mind you, how important the flexion extension views are and how much it changes your entire perspective in this case. Rohan, a quick word on this.
No, there is significant segmental kyphosis. It's almost toppling. I mean, the disc space is opening up completely. Mandates are global fusion, sir.
Yeah, okay. So flexion extension to the, the faculty, I mean, the students there and the residents, we did all that we could. So physical therapy, lifestyle modification, pain blocks was given. So what surgery now? Options. Each one of us. Let's go starting with Rohan. Hello?
A T-lift.
A T-lift for you. Open. MIS.
MIS is fine from the symptomatic side.
Okay. Amandeep.
The same, sir. MIS.
Okay. Okay. Vishal.
MIS from the symptomatic side, over the top first, followed by interbody, and a good size cage. And keeps looking at a muscle. I would keep cemented screws for this case as standby.
Okay,
If the muscle
okay.
level is not good, I would augment them too.
Sure. Dr. Gupte.
MIs from the symptomatic side, I may not do over the top because good size cage will open up the other side.
Foramen. So in that context, and both of y'all, I mean, I'll give this to Dr. Gupte if everybody agrees. What about the O-lifts? I mean, because you said, once I get the foramen done, it kind of solves most problems. So can you kind of enlighten us a few points about O-lift, whether relevant in this case, and if so, then
yes,
what are the
it
benefits?
is relevant. This is the ideal case for OLIF actually.
So benefits, if you can tell us the students and the fellows, benefits and some few points on the technique, if you can.
So you are restoring the disc height, and by restoring the disc height, you are restoring the canal size.
Correct.
Foramen opening. So that's
Correct.
the main thing. Yeah.
Correct. So Vishal, any points on that?
So
Olif?
other thing with OLIF here is going to be restoration of the sagittal parameters is much better now, according to all papers that have been published, because you can put in a larger cage via OLIF safely. The footprint of an OLIF cage is very large, so the chances of cage sinking, unless you have inadvertently damaged the end plates, chances are low as compared to a T-lift cage. I put a lot up to 17 mm cages from behind, but whatever said and done, the T-lift cage footprint is going to be low. So the chances of that case sinking in an unstable situation or an osteoporotic patient is high. So yes, this is an ideal case for OLIF. The only thing with OLIF is the way I do my OLIFs is I would do an OLIF, make the patient walk and multiple levels. Because OLIF makes sense if you're doing 2 or 3 levels. You're going to use BMP or allograft. So the costs involved are very high. So in the Indian scenario, I would still do in this case an MIS T-lift.
Okay.
And from the symptomatic side, but I would disagree with Dr. Gupte on one count of not doing over-the-top decompression. For the simple reason, if a muscle is so poor, the bones are likely to be poor, and in the chance that this may cage may sink in future because of osteoporosis prior to the fusion happening, then if I'm not done an over-the-top decompression, that is the time when I'll get into trouble. So that 1 in 100 cases where the cage will sink, I would want to decompress the opposite side in this case.
So we did the MIS T-lift. So for the students in a stable degenerative listhesis, a technically well done decompression alone may be enough. Release with fusion is not indicated. In case without fusion is not indicated in hypomobility, whether anteroposterior or angular, large disc heights, or extensive resection of facets. Instrumentation is a reference attitude and it helps good long-term results. Global and segmental sagittal alignment has to be kept in mind. And obviously, every treatment protocol has to be considered and adapted in the light of patients' comorbidities and needs. So if I can take the lights, any more questions from any side, any more comments before I have my last slide and then give it back to the BSS members?
Raghu, just one thing.
Sure.
Last case, let me
You
add that
want me to go back?
by protocol, all my patients, first time when I see them, I get their standing X-rays in lateral in flexion extension. by
Okay.
protocol each and every patient.
Correct.
So
correct.
this type of situation is not missed.
Absolutely. I completely agreed. And I think that's so important. That's the message to be given. So from all of us, to identify and classify the pathology is a key in the management of spondylolisthesis. Pain and disability justified by adequate imaging may decide the treatment protocol specific for each case, mind you. Monitored conservative methods work to a great extent in selected cases. If surgically planned, pelvic parameters and sagittal balance has to be taken into account. Achieving fusion and adequacy of decompression with correction of the deformity to the best possible with a technique adequate and comfortable for the surgeon matters. On that note, I would like to thank my faculty, including Vishal, Dr. Gupte, Amandeep and Rohan, for giving me a wonderful time to moderate this session. And I would like to give it back to Kshitij or Amit, if they are there. Or should I close off?
Yes, Raghu.
Amit.
Raghu, there's a question here on the chat.
Okay, I have
Can you
not
just-
checked that. Sorry. Sorry, 1 second. I missed out on the chat because it's like this.
In elderly patient with stable lytic listhesis with osteoporosis. Stable lytic listhesis with osteoporosis. You always put an interbody cage with posterolateral fusion, or you do chip lift with PLF. So only posterolateral or posterolateral with interbody with the graft only.
Anybody wants to take it? Vishal?
So I always do interbody. I take a lot of precautions that we don't disturb it, but I prefer to do interbody. But there is enough evidence to say that you can skip interbody work in extremely osteoporotic patients, do an adequate decompression, and just to. The only 2 times I have not put in a cage was where the T-score was -5+. Both were MIS T-lifts where I packed the disc space with cancellous graft, and that was it. Fortunately, both of them united because I think of teriparatide more than anything else. But that bone was so spongy that even a cage would have just smashed through the end plate. So that was the only 2 times we have put a chip graft inside. Both were rheumatoids and both were very, very poor quality bone. So that's my answer.
Any more questions? Amit, Kshitij? We are done. You want to kind of close or?
Yes. Thank you, Raghu, for running the show so beautifully. And thank you all the faculties. Our next meeting will be on 6th of June. So earlier we were doing it on every second Thursday night. But because for this meeting only, we came to know that on second Thursday, mostly the SC has their fellow teaching program. So we have shifted our meeting to first Thursday of the month. So the next month onward, we'll be doing it on like first Thursday. So we'll log in at around 8 o'clock and the actual meeting will start at 8:30 p.m. So next meeting will be on thoracolumbar trauma. So again, thank you very much for all the faculties and all the attendees. So
Thank you.
this program will be
Thank
available
you.
on the OrthoTV as well as OrthoTV website itself. So those who can, they can spread the word to your friends, the fellows and residents, and they can take the advantage of the program from there also. Thank you very much. Thank you again, everyone.
Thank you all.
Thank you. Thank you.
Good night.